Um, Hello, everyone, and welcome to Counterpoint. For those of you who are not familiar with Counterpoint, Counterpoint is ThinkWell's webinar platform promoting open and honest conversation around strengthening healthcare systems. We're excited to have you join us today, and once again, warmly welcome you on board. I am Nida Hamida Freedi. I'm a technical advisor with the ThinkWell Pakistan team. I'm a governance and public financial management specialist, and my passion lies in strengthening healthcare systems, particularly through promoting good governance and effective resource allocation. For many years, I have worked in this space, and I'm very thrilled to moderate our session today on provider payment reforms in Indonesia, its future direction, with a specific focus on integrated health system reforms. Today's session promises to be an engaging session, and we encourage you all to actively participate by asking questions and sharing your perspectives. Today's discussion centers on Indonesia's innovative National Health Insurance Program, Jaminan Kesehatan Nasional, JKN. So in my conversation from this point onwards, I would refer to the insurance scheme as JKN. JKN has experienced impressive growth in recent years, and the Indonesian government's dedication to continuous improvement is very commendable. Before we meet our esteemed panelists, let's take a quick look at the program's approach to healthcare provider payments, which is a crucial element in ensuring that JKN delivers to its promise. One key challenge is ensuring timely and sufficient payments to providers while minimizing unnecessary service use. JKN's strategy include utilizing capitation-based payments for primary care, which is a very well-established method for controlling costs while guaranteeing a definite set of services. This approach has demonstrably improved resource allocation efficiency, it has increased enrollment, and it has reduced the service overuse. However, even with a performance-based system, there's still room for optimizing referral rates to higher-level facilities. For hospital care, JKN has adopted and adapted international classification models and diagnosis-related group procedures. This ensures these systems better suit local needs and capabilities. By examining how JKN uses and continually updates its healthcare provider payment system, we can gather valuable lessons for achieving equitable and high-quality healthcare for all Indonesians. I'll stop here, and now let's give a warm welcome to our panelists who will delve deeper into these topics. I have 4 panelists joining me today. I'll start with Dr. Hasbullah Tabrani. We call him fondly Prof. He's an MPH and a Doctor of Public Health who serves as the Chief of Party for the health financing activity at ThinkWell and is a prominent expert in public health and health financing. He will share the background and the economic principles of prospective provider payments as they relate to the design of the JKN system. Dr. Tabrani has been working in the field of health economics, including health financing, for the last 3 decades in Indonesia. He has been instrumental in developing the National Health Insurance Scheme, that is JKN, with strong elements of strategic purchasing on the JKN. He was the senior health financing advisor to the National Social Security Council, the oversight body instrumental to the implementation of JKN to ensure the managed care and strategic purchasing techniques that he's designed 15 years ago and are implemented consistently. He studied health policy and administration at UC Berkeley in the USA. His network with international experts in health financing led him to convince the government and the Congress to commit to reach universal health coverage in Indonesia. He joined ThinkWell as a senior policy advisor in September 2018 and is a part of a senior leadership team in Indonesia on Gates-funded project and other projects in current startup phase. Since August 2019, he has been in charge as Chief of Party for the health financing activity of the USAID and the Ministry of Health project for 2019 and 2024. We welcome you on board, Prof.
Thank you. Too long. All right, but okay, Nida. Thank you.
Next up is Dr. Atik Nurwayuni. She's a master's in public health financing expert from University of Indonesia. Dr. Atik is a well-known specialist in the diagnosis-related group, Indonesia's case-based group payment system, and cost accounting in healthcare services. She has been conducting research and delivering courses and training on DRG, CBGs, and healthcare financing since 2009. Dr. Atik has also been a member of the National Case Mix Center at the Ministry of Health in Indonesia from 2012 to 2015, and currently holds this position again since 2022. Dr. Atik graduated from the Faculty of Public Health at University of Indonesia with a bachelor's degree in hospital management in 2000. In 2004, she received her master's degree in health economics and health insurance, and 2015, she obtained her doctoral degree in public health from the same faculty. She has attended various courses in many countries, including the International Long-Term Training in Social Security in Germany and the Netherlands, health financing courses organized by GIZ in the Philippines and Cambodia, and a DRG course in Nicosia, Cyprus. Additionally, she completed an internship at AOK, Germany, to learn about the implementation of the DRG payment system. Currently, Dr. Atik teaches cost accounting in healthcare services, health economics, social health insurance, and a healthcare provider payment system at the Faculty of Public Health, University of Indonesia. A very warm welcome to you, Dr. Atik.
Thank you, Nida.
Next panelist for us is Professor Dr. Ali Ghufran Mukti, who is an MSc and PhD. He's the President Director of BPJS Kesehatan in Indonesia and an expert in the field. He will speak to the IT support system, pay for performance models, and the current progress in provider payments. Formerly, he was the chairman of COVID-19 Research and Innovation Consortium and also acting expert staff of infrastructure in Ministry of Research and Technology, National Agency of Research and Innovation, Republic of Indonesia. He was former Dean, Faculty of Medicine, UGM, acting President, University of Trisakti, Indonesia, and the Commissioner of Mandiri Health Insurance Company. He was the Director General of Resources for Science, Technology, and Higher Education in the Ministry of Research, Technology, and Higher Education. He's committed to research in the area of epidemiology and health insurance. He managed healthcare and health financing, and is an international expert with more than 40 journals published. He was also former Vice Minister of Health and Acting Minister of Health. He's a guest lecturer in many world-class universities such as Harvard Medical School, Nottingham University, Tokai University, etc. In the 1990s, he took sport health insurance courses in UCLA. Dr. Ghufran, a warm welcome to you too.
You're welcome. Thank you.
Thank you. So next and the last speaker that we have today is Dr. Ahmed Irsan Moez. He's a bachelor's and master's of economics, head of the Center for Health Financing and Decentralization Policy in the Ministry of Health Indonesia. He will discuss how the government employs capitation and case-based groups to enhance the effectiveness and efficiency of JKM payments. Due to conflicting agenda, Dr. Irsan unfortunately could not attend and is represented by Febriancia Budi Pratima, who is a bachelor's in public health. Febriancia is a member of Dr. Irsan's team and currently working as a policy analyst. He is instrumental in the process of improving the capitation and fee-for-service tariff for the JKM program. He completed study at the Faculty of Public Health, University of Indonesia, majoring in health administration and policy. He has extensive experience working in the health insurance sector at several private insurance companies as an underwriter. He has obtained certification in health insurance at the associate level. Welcome, Febriancia. So I once again thank the panelists for joining in today, and I'm sure you'll all bring a bundle of knowledge for all of us to benefit from. Before I move forward, I want to take this opportunity to thank two of my ThinkWell colleagues. The first is Caroline Mohan, our communication manager. She has been instrumental in setting all this up, and she will be recording today's session and sharing with you all and for others who could not make it today in the webinar. Please note that as an audience member, your name and other details will not be recorded, including if you post questions. The other colleague of mine is Ifa Husnul Kotema, HFA Health Financing Specialist. Ifa has graciously agreed to monitor questions and comments posted online and select a few to post to our panelists in a dedicated session in the end. So keep those questions coming by using the Q&A box that you see on the screen. We will try to get to as many as possible. As I noted when I began, we want this to be a free and frank discussion, and we may not agree on everything, but we all agree that we benefit from exchanging ideas openly and respectfully. We are here to learn from each other, and I believe that a respectful dialogue is key to a productive discussion. Okay, so let's start the discussion. We'll be covering 4 segments in the webinar today relating to different dimensions of JKN. Each segment will last for 15 minutes, where I'll ask questions from our esteemed panelists. I would request the panelists to restrict their answers to 3 to 4 minutes so we can cover maximum questions. Without further ado, let us move to the first segment. So a very central challenge for any healthcare system is balancing the need of high quality care with the need of cost control. In this segment, we'll have a look at Indonesia's multifaceted provider payment system. We will highlight the innovative aspect of JKN's approach, such as adopting international models that they learned from Europe, Australia, US. We will discuss how has Indonesia incentivized healthcare providers to deliver the best possible care to patients and see the successes achieved in terms of cost control and enrollment growth. We will explore the ongoing refinement process and Indonesia's commitment to continuous improvement while identifying potential lessons learned for other countries to reform their healthcare systems. So I think I'll start for this session. I'll start with Prof. Hasbullah.
Sure.
How do you think, how are the economic principles of prospective provider payments applied in the design of JKN system? And also, additionally, were there any challenges or unintended consequences associated with applying these economic principles?
Yes, thank you, Nida. When we designed the JKN, the National Health Insurance, we were blessed by a previously ASEAN crisis of health of the financial system that lead to a strong commitment by all parties to reform many things, including the healthcare system. And we have also experience before with social insurance scheme, with ASCES for at that time 40 years. So we identify clearly the nature of healthcare, which is basically has 3 different main characteristics, which is uncertainty that lead to requirement for applying health insurance or tax-funded system to ensure everybody get healthcare when they need. The second characteristic is this is the key for the provider payment system, which is the information asymmetrics. The knowledge of doctors, hospital, and the patient, huge difference. And therefore, this in economic theory, this information asymmetric can lead to the moral hazard, fraudulent, and supply induced demand, and many other aspects that not appropriate for the market mechanism. And therefore, we identify that if we used to pay fee for service, certainly will inflate the demand for that one. So the key is making the provider at financial risk if they provide more services when it is not necessary. So this is the key principle. How do we provide financial incentive for them is we pay them at the prospective payment. We decided the package in advance, and we determine the price in advance, such as capitation or DRG, or here we call it CBG. And Ibu Atik will discuss more on more detail. So that's the principle that we take lesson from many health economic literature and best practice in many countries, and therefore we adopt that one. Certainly there are challenges because most of doctors, hospital in Indonesia, public or private, were used to fee-for-service method. They don't really understand what the capitation and CBG. Therefore, until now, they're still complaining that the fee is not adequate, is not we lost and so on. That's still happening. Certainly, it takes some time to make all this transition work well. Yeah. So that's some unintended consequences. Some of them because of the perceived low CBG, then they make it readmission, they're taking back and so on to maximize the revenue. That's a normal business process, yeah. And therefore, we have to also set other method, such as Prof. Gufron will tell you later on, how do we verify to ensure that the process, the procedures are met. We also did the credentialing process. Not every healthcare providers can be contracted, and so on. I think Pak Gufron will tell you more later on.
Prof, I have a second question to you.
Okay.
How did Indonesia decide on that mix of provider payment methods? How was the decision reached to adopt to a particular mix of provider payment method? As in what, how much for capitation and how much for the other? Yeah.
Yeah, well, as I told you before, we already have implemented social insurance before for civil servant, and we learned from the US model on managed care, HMO, in the 80s, and we implemented already in ASCES, the previous social insurance for civil servants. The method is simple. We know that economically, all services has different distribution, cost distribution. For primary care that are relatively not many medical intervention, the distribution of cost relatively predictable. And therefore, we can apply that using the capitation system. And now we do adjusted capitation because of the different rates for different age group and different gender. For the hospital services, certainly is very huge if we compact it into one price. But if we look at the distribution of cost, this is what we calculate before. With distribution of the cost distribution by disease, by case mix group, we know that the distribution relatively slim. When the distribution of cost to produce certain diagnosis, certain medical condition is slim, then we can set up a group of the price for that one. So that's why we came up with a different group, or we call it CBG. Initially, the grouping method used the United Nations University grouper. Before that, the 3M method. But now we found that, Ibu Atik will tell you later more, we found that those grouping that normally used in Malaysia not really perfect for us with the different background healthcare system before. Now we are developing a grouper, we call it, to make sure what is the distribution. I think Ibu Atik and Febri will tell you in the process on that one. Yeah, that's where you do it. So it is basically evidence-based on cost of distribution of cost in producing certain level of services. Certainly, the quality is important element.
Thank you, Prof. Thank you, Prof. I think I'll shift the question now to Dr. Atik, asking her, since she is an expert in this, can you explain the process of establishing case-based groups in Indonesia and the impact that they had on hospital payments? Dr. Atik?
Thank you, Nida. Actually, the CASMIC system was first developed in Indonesia in 2006, called INA-DRG. The implementation of this payment began in 2008 in 15 hospitals, and in 2009 was expanded to all hospitals that provide health services in the Jamkesmas program. On 2010, the nomenclature was changed from INA-DRG to INA-CBGs, in line with the grouper change from 3M grouper to UNU grouper, like Prof. Hasbullah already mentioned. Then with the implementation of national health insurance, which began on 2014, the INA-CBG system was again used as a hospital payment system for both outpatient and inpatient. The implementation of CASMIC payments has a huge impact on hospital because there is a change in payment system from fee for service, which has been used for decades in hospital, to CASMIC. The fee for service economic signal is very different from the economic signal provided by INA-CBGs. With fee for service payments, to get high profits, hospital will tend to increase the number of services provided to patients, while this is contrary to the economic signal given by INA-CBGs. In INA-CBGs payment, hospital will get profit if they are efficient. So currently, hospitals are more aware of how important it is to have a quality data, starting from a medical record data, so that the claims process will smooth and optimal, and as well as cost data, so that they can monitor and evaluate the cost incurred, as well as to develop efficiency strategies. Hospital also develop clinical pathway to maintain service quality at control costs. Regarding the grouper that I mentioned earlier, usually countries that implement DRG payments will update their grouper regularly, 2 or 4 years. So that is in line with the developments of medical technology and cases in that country. The UNO grouper has been used for 14 years without any significant update in its classification. So actually, some countries are faced with two choices in implementing DRG payments. First is develop their own disease classification algorithm or grouper, and second, adopt the grouper from other countries and then modify it. Indonesia followed the same pattern as in many countries by taking the second option. To develop disease classification, we adopt from Thai DRG, that Thai DRG adopt from Australia. Starting in 2016, the Ministry of Health initiated collaboration with professional association to develop INA grouper based on patient data, which reflect the pattern of clinical practice and the use of resources in Indonesia. In the future, the INA grouper will be used to replace UNO grouper. After a long and winding road, INA grouper is now entering the trial phase to classify the cases, but still paid by based on UNO grouper right now. But it is a significant achievement and will become a milestone of DRG implementation in Indonesia. Thank you, Nida.
Thank you, Dr. Atik. Thank you for explaining the process so well. I think we're just left with last 4 minutes in this segment. So I'll just pose a general question to all the speakers. So JKN's success hinges on its ability to cater to the unique context of Indonesia's healthcare system. How has the system been refined over time to fit Indonesia's healthcare context better? What kind of specific adjustments and refinements were made to the provider payment system to better fit the local needs? Whoever wants to answer the question. Prof?
Yeah, hello?
Yes, Dr. Gofran.
Oh, yeah. Yeah, I think actually, as far as I know, as mentioned by, of course, Abu Atika, Abu Atik, that already long time we have not yet revised. I think it is important to revise, but of course that it should not be, make more confused to the, especially doctors and hospitals. And of course, the revision is important as far as it is to be making sure that the provider payment will be much just or can be accepted by all the healthcare providers across the countries. And I think as far as it is make it easier and adjust, meaning that those who working hard and working more will give more money, will get more money. I think the problem in Indonesia usually that it is depend on the negotiation and depend on the role. For example, if, for example, those who have a big role is in I expert, then most of the provider payment in I sectors and I provider payments is get more money. For example, like cataract operation using FICO maybe got more money rather than compared to the for example like Caesar operation, for example, something like that. Okay, so as far as it is make more just and make more acceptable to all healthcare providers, I think it's okay. Thank you.
Thank you, Dr. Gofran. Thank you. So this brings us to the end of our first segment. So far, we have explored the impressive strategies JKN has implemented for provider payments. Now let's move to part two. Here we will discuss the key system capacities needed to JKN to keep refining its provider payment reforms as the program evolves. Additionally, we'll also see how JKN ensures its reforms are effective across healthcare needs. We will discuss how these system capacities for continued reform might differ depending on different priority health areas. So I think I'll start with you, Dr. Gofran, and ask you what are the key capacities needed in the IT systems and the M&E processes to support the continued provider payment reforms? And do you see any role that the IT systems can play in ensuring transparency and accountability in provider payments?
Okay, Nida, thank you very much. So can give us to the second slide. Second slide. Yeah, just to make sure that you know what we are discussing about. So that is the business model of BPJS Kesehatan Protection System in Indonesia. So first, of course, that there are members. The members basically we have three subsidized members. Then which is where the employees pay 1% from the salary, and then the employer 4%, and then contribution those who informal sectors $3 per month for each person, each member, then $6, then $10. Okay, then this all members, the important here, we already integrated system into single scheme, and the coverage not only 96% here in the basic, basic here. Sorry, can little bit up. Cannot see it. So in the basic of the slide, can we little bit up of the slide? Can we draw little bit? Okay. Sorry. So now cannot read. Okay, deficit previously and now to be positive surplus, and we gave down payment to the hospital and providers, so they are now happier compared to before, although they are not yet optimum happier. And we increase the tariff and satisfaction increase, also out of pocket payment reduced from almost 90%, 50% to only 25%. So basically here, the function of BPJS Kesehatan not only, revenue collection we collect from our members, but also risk pool and strategic processing to providers. How to purchase? So first, we use transformation, quality transformation with 3 indicators: easier, faster, and non-discrimination. And of course, how to pay to the primary healthcare, we use capitation-based, we use performance-based capitation and risk-based capitation. But to the hospital, we use INA-CBGs and non-INA-CBGs, and we have medical advisory board and also control, quality and cost control team. And we also have, those who are trying to see the performance. So therefore here, all main activities are supported by advanced IT system. So what actually the main, capacities that is needed by, our system, which is not only management capacity and knowing technical capacity for IT system, but also how actually protect the system from hackers. Because now almost every day there was trying the hacker to hack our system. So by using IT system, of course, that it is very important. We know not only technically IT system and protect the system and security of the system, but also we have to know how to read and really know about the performance of each health facilities, both primary healthcare and hospitals, and also the healthcare providers, for example, surgeon. How many surgery a day that we have to be able to supervise and know exactly. And not only that, but we have to be transparent, as you mentioned. The hospital not only be able to submit their claim, but they have to be able to see transparency where and when and in which stage the claim is. For example, just submitted or in the process of verification or in the process of waiting for the payment. And we pay only less than 15 days usually. So I think it is enough or not enough. Of course, the accountability is very important because each of parties will be able to know exactly what they are doing, the performance, not only performance, but also the claim. So again, for the capitation, we're not only using capitation for primary care, but performance-based capitation and risk-based capitation, meaning that those primary healthcare have more risk, we will pay more based on the, for example, age and also the probability of the sick of the population. I think that is clear or not clear?
Yeah, thank you, Raghuvan. Thank you. So I understand that the various system capacities are required across various areas, such as data management, as you spoke, a standardized set of quality matrix, elements of transparency, elements of communication, also backed by a robust regulatory framework, so on and so forth. There could be a lot of system capacities that you can mention here. So Prof. Hezbollah, I want to ask you, what system capacities were crucial in supporting the very initial implementation of JKN's provider payment reforms? So I just want to understand, where did you start from? What were those system capacities which you started with initially in JKN?
Yeah, I remember between 2013 and 2012, 2013, when we want to start it with the new price, new CBG price, and also contribution price. For 2 years, we did analysis of previously ASCAS and then the Social Security for private employees, and assessment of various data that we have from national statistics, to assess the capacity of people who pay contribution, and the estimate amount of money that can be generated in order to make this decision how much money we will pay for the providers, and what the amount of money for certain CBG or certain group, and capitation. That based on the studies and data analysis, because payment system must be evidence based. Otherwise, the system will not work. We have to pay to ensure that efficient, but not too low, that the provider will not be able to meet their costs. This should be on average cost, although it's not that easy because of the complexity of the system. So the capacity first is the making sure the data on costs or price, if not cost. Normally, we have the easier data on price, not cost. Yeah, that should be available in large enough. Yeah, we continue doing that. Even currently, also we are collecting data to estimate the cost of production, certain diagnosis, the capitation, and also Gufron and team are piloting the global budget mechanism to see how good is the data to be based for the decision making, to be rational. The second one, if we have good information system, then currently the BPJS, Pak Gufron already have more than 200 million data every year. Yeah, data claim data. The second one is the capacity of human resources to analyze the data. Yeah. Otherwise, if they cannot analyze data, then it will not be good information to make a decision. And then afterwards, certainly we have also to educate all the policy makers who will make a decision, because the process of analyzing data will be done by technical team, while decision making will be done by upper level of official, the minister, Pak Gufron, the council, and so on. Then afterward, we have to be adequately socialize, inform the public, so they can accept all this decision. If we don't have that one, there will be a risk that the public will reject and create some big problem. So if we do that, inshallah, the system will work well. Over. Yeah.
Thank you, Dr. Hasbullah. So, so very, very well put, and you have covered all the essential elements that are crucial for the system. Let us now move to the monitoring and evaluation aspect. I'll pose this question to Fabriancia. So what monitoring and evaluation processes are crucial for ensuring the effectiveness of capitation or case-based groups? And also, if you can cover how these processes differ across various health areas. I mean, see, as in one size may not fit all. How JKN's payment processes might vary across different healthcare settings. For instance, how many payment structures, how might payment structures differ for primary care compared to specialized care? Or maybe how would payment systems differ for chronic disease management compared to maternity care? Can you shed some light on this?
Okay, thank you. So generally, as the other speakers said, that generally in JKN, we paid the healthcare with capitation and CBGs or DRGs. And the rest of them, we pay with fee for service. At the additional of capitation, we add the pay for performance, like Prof. Gufron said. We have KBK, capitation based on performance. And then what is difference and we differ the payment system? Let's say if in primary care we have the capitation special tariff for the remote area, and we think that this is the we must monitor whether this is the right payment system or not. Let's say the capitation is maybe work if the primary healthcare have the enough participants. But let we think that if we have puskesmas in remote area and they only have less than 1,000 members, is it enough if we pay them with capitation? And we still in working and the calculate the right method of payment for this puskesmas. And how about the chronic disease management? As we said, we have the non-capitation or fee for service tariff. So we move some of service that we think cannot pay with capitation. Let's say with diabetic. In the capitation, additional from capitation, we add fee for service for the screening and the uh, blood blood test like HbA1c. The tariff is different from capitation, and we think that if we try to monitor, we still not the tariff is not working in every puskesmas because we have the issue of autonomous financial management in puskesmas. Not all puskesmas can pay with fee for service because they cannot uh, even use the earning from non-capitation or fee for service to buy some reagent or some services like that.
Thank you. Thank you so much, Fabriancia. That's very, very enriching. So this brings us to the end of our segment 2. Now we move to segment 3. Up till now, we have looked into the core payment methods and the key system capacities of JKN. And now let's explore some cutting-edge approaches. So in this upcoming segment, we'll discuss incentive structures and experiments that Indonesia has implemented to move towards a value-based care model. For those of you who are not familiar with the value-based care models, it shifts emphasis from the number of procedures or visits to a measurable improvement in a patient's health. And the provider ultimately gets rewarded for the positive patient outcomes. So here we learn about the successes and challenges that Indonesia faced in incentivizing quality of care and performance while experimenting this model. For this, I'll start with Fabriancia again. So Fabriancia, what types of budgeting experiments have been conducted to incentivize quality care? And did they show some results? And I have another part of this question as well, where I want to see and discuss how it impacted, how these experiments impacted the provider behavior and the patient outcomes. Can you please discuss that?
Okay. Maybe I will tell more about the primary healthcare payment. So we have implemented to pay for performance to conduct the quality of service in primary care. So we have already implemented the KBK, capitation of based on performance. Let's say we don't have the incentive yet, but we disincentivize the PHC if they didn't reach met the 3 indicator that we set. Let's say if you paid monthly 100 million rupiah and you didn't met the indicator, BPJS Kesehatan will cut the payment at maybe 5 to 15%. And as far as it goes, KBK is achievement is increasing in every FKTP or PHC, and yet this improvement is giving the increasing of primary care utilization. So we can simplify that KBK is related to quality improvement in primary care. But if we look more deep, that change of behavior of the PHC in puskesmas, clinic, and etc. is not directly impacting the referral service. Regularly, if we tell that more patient treatment in the primary healthcare, there will the decrease of the referral in hospital. So the KBK is not giving that result, and that's why we have the monitoring evaluation process, and now we are working with Professor Gufron team in BPJ Kesehatan to refine the KBK or pay for performance. The first is we move from the disincentive or penalty, and we adding more incentive if PHC met some of additional pay performance, and then we will add more indicators, and let's say the indicator is more to chronic disease management. We hope if we add this indicator, the cost is shifting from hospital to PHC. And then we will have the piloting to make sure that the target is not high enough. So we will set the target, achievable target to PHC. Because if we set the target too high, the FKTP or the PHC is they will say, is it possible to achieve? And it just be just cut my capitation is fine for me. And then nowadays the Ministry of Health is piloting the treatment of tuberculosis. So the idea is if the incentive, finance incentive, will increase the treatment of tuberculosis. So we have the piloting in 6 cities, and we gave them the incentive if the FKTP met the treatment of TB tuberculosis. So if the members of Puskesmas and the Puskesmas treat me the tuberculosis care complete in 6 months, they will receive the incentive. But still there is some problem. I say before that not all Puskesmas can directly take the incentive because they have not non-autonomous financial management. So they burden with the regulation of the local government. So the incentive is not directly goes to the health facilities. So that's from me. Thank you.
Yeah, thank you, Fabriancia. So I think I would frame this question, the next question for Professor Gufron. Can you also share some specific examples of pay-for-performance models that have been successful in Indonesia? And what has been the key outcomes in terms of cost control and quality of care both? Professor Gufron?
Yeah, it is possible that we can see the comments from my slide, just one slide.
Yeah,
now
coming to see the command center, I found the command center also something that is remarkable. I mean, it helps you to get a feel of what is happening on the ground, and then how it is being used also to drive enrollment and all. I think I'm highly impressed. Yeah.
So to come back to Indonesia and to see the BPJS now and what it's achieved is really quite impressive. So I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population. And I think I'm still learning about BPJS, but what I can say is I'm impressed with how much it is innovating and testing and experimenting with new things. To me, the things that are most exciting are the things that make healthcare different for the individual. So making access easier, bringing services closer to the individual or to the community. I think the ways that the BPJS is innovating and finding ways to do that, that's what impresses me most.
Impressive. So the coverage that BPJS has is something that many countries aspire to achieve. So in many ways, it's a place that we can look to learn and see what's being done here that we might be able to transfer and use in other parts of the world that are not as far along in different aspects of health. The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about.
I was very impressed by the digital transformation, and I can't imagine how they handled 1 million insurance claims a day. So I was very impressed by how efficient the leadership, how efficient the management of everything was.
So I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, lower middle income countries that are aiming to achieve universal health coverage. The experience that Indonesia has had provides invaluable lessons to many countries that are on the same path, which Indonesia has almost achieved near universal, decreasing out-of-pocket expenditures, improving service delivery quality, as well as improving efficiency. So I think the world is looking towards Indonesia for your country experiences and how we can go back and emulate the same in our country.
BPJS keren.
BPJS Kesehatan keren.
BPJS Kesehatan keren.
Okay, thank you very much. Okay, so Nida, I think your question is that how actually the IT not only to achieve in helping, there are three functions: enabler, then driver, and accelerator to achieve universal health coverage, but also payment mechanism, which is more just, and also as your questions, to reduce the cost or make more efficient and increasing the quality. For example, in primary healthcare already, explained by Ministry of Health just now, but also actually for hospital, for example, Pak Febriansyah already explained in primary healthcare. Also, actually, I wanted actually to add some more information, but anyhow, it is because of the time. So I just talk in the hospital. In the hospital, actually, now by using IT and provider payment supported by IT, very easy to detect, how many frauds, as mentioned by Prof. Hasbullah, and fraudulent. And also, we know exactly behavior of health facilities across the country, real time, every day, more than 1.7 million transaction that we can capture. So it is really amazing. And 1 year we have 606 utilization or transaction that we can capture, and we know exactly how many hospitals are committed to fraud, and we can reduce cost. And not only that, for the quality, for example, compliance, then we be able, now pay installment or pay in advance. Those who have very good or better, performance, then we will pay more in advance. For example, up to 60% of the claim. And not only that, but we know exactly now people can, after receiving services, they can give feedback whether the services is good or not good, the complaint or not complaining, thing like that. If too many complaints and they are not satisfied, the patient not satisfied, then we will give feedback to the hospital. If the hospital still doing the same thing, still, discriminate BPJS patient, then we will not, MOU or collaboration anymore. Then the hospital will very difficult to survive in Indonesia if they are not working together with BPJS Kesehatan. So here is very clear how to increase the quality. So patient can give feedback, for example, giving rating 1 star, 2 stars, giving 3 stars up to 5 stars. not 7 stars, because it is different if 7 stars. So I think it is clear. If not clear, then I can explain in detail. Otherwise, thank you very much, Nida.
Thank you, Dr. Gofran. I think you've explained it very well, and I think it's really inspirational work, as said in the video that you shared, that other countries can learn from as well. So unfortunately, you won't be able to cover any more questions in this segment, but this brings us to our last segment, which is the part 4 of this webinar. And in this section, we'll turn our attention towards the future and explore how JKN's provider payment methods can be further aligned with Indonesia's ambitious health transformation agenda. So we'll further discuss the changes JKN might need to make in its provider payment processes to achieve the goals of an integrated, promotive, life cycle, and preventive care. So I think I'll start with Dr. Atik for this section, and I would ask her for her recommendations for aligning hospital payment methods with the goal of the transformation agenda. Dr. Atik?
Okay, yeah, thank you, Nida. Yeah, actually, by theory, a provider payment system can be powerful tools to promote the development of health system and achieve health policy objectives. We know that there are 6 pillars of the health transformation agenda. First is primary care transformation, and then rural services transformation, health resilience system transformation, transformation of health financing system, transformation of health human resources, and health technology transformation. In fact, actually, INACBG's payment system are closely related to all existing pillars. However, directly, the INACBG's payment system must be designed to support the achievement of the goals of Pillar 2, that is referral services transformation, and Pillar number 4, transformation of the health financing system through periodic tariff reviews with, of course, accurate data, and continuously improve costing methodology, as well as a regular update for INA grouper, the classification to be in line with the medical technology. And this is what actually the Ministry of Health Tariff team continues to do. But currently more than 80% of JKN funds are allocated to pay hospital using INACBG's payment system. In relation to pillar number 4, transformation of the health financing system, which aims to ensure adequate, fair, effective, and efficient financing. INACBG's system cannot be separated from payment policy in primary healthcare. Both types of payments are very good, capitation and DRG, CBGs, but we know that there is no payment system is perfect, because each payment also create unintended consequences. It's also happen in capitation and in DRG payment system. For example, primary healthcare is paid by capitation, which has one of unintended consequences is refer patients to hospital, and hospital are very happy to receive referrals from primary care because they will be paid per visit by BPJS Kesehatan. Currently, the hospital can claim all the visits they serve without any limit on the number of cases. So actually, there is an instrument is needed to control the increase of hospital activity so that the national JKN budget is sufficient. Almost all countries that implement DRG also combine their payments system with the global budget, for example, to ensure the budget sufficiency and sustainability program. By combining the CBG's method with a global budget, the national budget can be allocated properly, transparently, and accountably to all the hospital in accordance with a hospital performance. With a global budget, hospital will know how much money they will receive next year, so they can plan well. However, this global budget mechanism should be implemented in the regional level because it involves the primary care. I mean, the money is not given to the district government, but the implementation mechanism involves the district government, district health office, primary healthcare, and hospital, of course. Because without a strengthening and intervention in payment for primary healthcare, the budget that has been allocated to hospital will very likely not be sufficient. Probably it is important for the mixed method payment system, CBGs and global budget, start being considered and discussed by stakeholders, policymakers, and also academicians. Thank you, Nidia.
Thank you, Dr. Akin. This was very, very knowledgeable. So I want to ask Prof. Hasbullah for his recommendations for further refining the payment processes to align with the transformation agenda of Indonesia. Prof?
Yes, Nida. I think I will like to a little bit give comment on the current system that's my colleague mentioning the local government don't give the money and so on. That's very unique in Indonesia, where we are transforming from previously mixed public finance, where local government has the authority to manage the money for their own private, public providers owned by local government. So by law, they have the money by, if the hospital, local public hospital or public health centers receiving money from BPJS, then by law, the money belong to the local government. And when we provide incentive for public providers and the money kept by the local government not going through the healthcare provider, certainly the impact of incentive for the providers, the doctors, the human resources will not work. So that might not be happening in other countries. Yeah, and then for this payment model, the risk-based payment, we call it, is perfect for the private sector, private providers. They can respond quickly to incentive, disincentive, performance incentive, or performance disincentive. That's the difficulties. And therefore, we need further reform to make the providers, like in many European public hospital that's already well developed in Germany, in the Netherlands, in the UK, where they have much more autonomous to manage their own money without interfering by the local government. So this is the reform that we are going to do, or recommend that the government should reform the overall system, because the reform is not finished yet. We reform the financing model for the medical care, but there are still also public health problem where the national government, local government are responsible to finance. And the mindset is, when we do have our hospital, although this is public, the money is ours. And when they pay the subsidized contribution for the low income by the local government, they think, oh, this money is our money, and therefore BPJS should not contract the private provider for this one. So that's kind of reform needed to align the full concept, full implementation of the application of economic theory for the healthcare providers, where the economic theory already identified clearly that the healthcare providers is not fully fit for the purely market mechanism. So part of it is the complexity, how to transform that one. So this is what we recommend, making identification clearly and slowly change the public financial management, and also reducing duplication of the JKN or national insurance paying and direct government fund channeling to local hospital or local public health centers, then we will observe a better response to prospective provider payment. But some payments not fit for the prospective payment, and therefore we carve out, we take it out. For example, for the drug for chronic disease or a drug for cancer treatment, which is separate. So that's what February mentioned as still using fee for service. In other also the mindset fee for service, complaining that we are losing for this diseases. That also require other model, as Bu Atik mentioning, of the combination with the global budget. So that's the nature of complexity of the healthcare system. But if other countries can do it, we have to do it. We can do it also. Thank you.
Absolutely, Prof. That's spot on. So I think let's move towards the policy space, and let me ask Febriancia.
Can I add some more information in Pak Hasbullah explanation?
Yeah,
absolutely.
Yeah, I think basically in Indonesia, provider payment need reform, but of course, it is not only provider payment. It is more than the provider payment. So like Prof. Hasbullah mentioned about the autonomous of the financial management in each health facilities like hospitals or primary health care. So it is very important, not only again provider payment itself, but beyond that. So the autonomous of the health facilities, both primary health care and hospitals, are vital here. Not only that, actually, but how the IT can really help and facilitate and enable that each of the policymakers not only analyzes the data from the IT supporting system, but also how actually we really know exactly who and which hospital and doctors are performing well. If they perform well, then we can give incentive in the provider payment. And of course, to many needed, and we have to be careful. In my opinion, that now actually, again, we have to see beyond provider payment method. Provider payment method, okay, we look at this and we already, in my opinion, advanced compared to many countries in ASEAN. For example, in Vietnam, they are still not yet capitation. And we, of course, mentioned by Prof. Hasbullah and Febriancia, not only capitation itself, but capitation and non-capitation, Pak Febriancia mentioned as for fee for service, and also for INA-CBGs, or DRG, we are not only in a DRG, but also carve out or beyond, not only in a CBGs, but also using a claim and fee for service or non in a CBGs, we call it, for various type of those who are not, fair and just if we pay only using, prospective payment in a DRG. Okay, thank you.
Thank you for adding that explanation, Dr. Wolfram. That was very, very helpful. So my last question is to Febriancia. What are the policy changes that you think are required to optimize capitation and CBG payments in the light of the transformative agenda and to reach the future integrated health system reform that we are seeing?
Okay, thank you for the question. I think before the policy, we must evaluate our system now, our payment system. First, we have already refined the tariff in Ministry of Health Decree number 3, year 2022. we must evaluate whether there is a cost shifting. Buati says that over 80% is goes to hospital. Yes, I agree. And after the permanent case 3, it's worsened. About 87% is goes to hospital and is increasing. Yes, there is something wrong with our tariff refinement absolutely in primary care. We already increased the tariff as non-capitation fee for service, especially in maternal neonatal. We gave a 40% increase for the birth delivery, but yet there is decreasing birth delivery in FKTP. We know why. That's because it's that not effective, and that's the issue of autonomous financial management in Puskesmas is blocking policy. And then I would say that we must give the evaluation of our capitation system. We still didn't reach. How about the remote public health care or primary health care in remote area? We must develop new payment system, not capitation, not special capitation, but maybe we can move to global budget as Prof. Hasbullah says. It is because it's not relevant to pay them with capitation because they have so low participant. And the second one is we must revise the financial management of Puskesmas, as Prof. Hasbullah said before. We must give the full autonomous for Puskesmas so they can more sensitive with our tariff change. Yet we already changed the tariff, and now we see that they're not sensitive with it. The tariff increase is not change their behavior. And the third one is we must set the clear standard of healthcare delivery. So we have moved to prospective payment, and it is very effective to suppress the cost, but we still asking the quality of service. So let's say I am goes to hospital, I have typhoid, BPJS paid with CBGs. Whether I discharge in 3 or 4 days is the same. And the hospital said that you must discharge in 2 days. So the patient has the most one that have the negative impact of this. And then we still have the monitoring and evaluation periodically with BPJS Kesehatan and also district health office, because district health office have the role important. They can reject the operational of the hospital if they not comply with the standard. And the final for me, we must refine the P4P system with stick and carrot. Nowadays we just have the stick without carrot. So if we should incentive them more if they met the performance indicator that we set, and then the supply set Prof. Gufron, Ministry of Health must revise the supply side readiness, because we only care about the demand side. Sometimes we forget about the supply side. So we have the North Maluku, we have the Papua, and yet they still have the Puskesmas on there. They still have no doctor. So it's the homework for the Ministry of Health. Thank you, baby, for me.
Thank you. Thank you, Fabriancia, and thank you, panelists, for those insightful points. They were really helpful, and I think participants will learn a great deal from them. So with this, we come to the end of our segments. We have covered a lot of ground today. Although we are nearing the end of our discussion, we have a dedicated slot for Q&A from the chat. And my colleague, Ifa, has been gracious to monitor the chat. And she has picked some questions for our panelists from the chat. So over to you, Ifa, for this section. And I would request the panelists and Ifa both to monitor the time, and please restrict the discussion to 20 minutes.
Thank you,
Over
Nida.
to you, Ifa.
Thank you, Nida, and thank you for all participants for the great questions. We have 5 questions here, but our apologies, due to the limited time, we can only select a few until we reach 5 o'clock today. So the first question is coming from Pak Dono Widiatmoko. Pak Dono asked, how do Indonesia address differences in cost structures in the payment system across different geographies and ruralities, as presumably their costs are different? Maybe this question could be directed towards Dr. Atik and Mas Febriansyah. Please, Dr. Atik and Mas Febri, the floor is yours.
Yeah. Okay. Thank you. BGs we have the INASI BGs have we call it adjustment factors. Adjustment factors. One of the adjustment factors is regional. So the tariff is set differently among the regional. They spread to 5 regional 1, 2, 3, 4, and 5, based on the provinces. Yeah. When we calculate or when the Ministry of Health calculate the tariff, actually they used wages, minimum wages, because the majority of the cost in a hospital is for labor costs. That's why the Ministry of Health used wages as a variable when they set the tariff for the regional. But for the next tariff, Ministry of Health tried to also involve some other variables, for example, the access and also the poverty. But we will see how the result if the 3 of the variables will be used. Yeah. Back to you, Ibu Eva. Thank you.
Thank you, Dr. Atik. Maybe now Mas Febriansyah's turn to answer the question.
Yeah. Unfortunately, still now in capitation and pay for performance, we still didn't have the adjustment for the regionality. But in a remote area, we adjust the tariff more higher than the rural or maybe in the city, in the urban. And also in capitation fee for service system, we have the negotiation process with BPJS in Prof. Gufron team. In every the branch of BPJS Kesehatan, they will set the tariff based on their negotiation. So if the maybe in Java or in the North Sumatra, there is the difference is whether they will pay the primary inpatient care. So the difference is still negotiation. But in the future, as Buati say, we will have the additional adjustment for the tariff for capitation. Maybe we have to set the regionality as the CBG team set. We still collecting the costing data for every sample that we select, and we will deploy the adjustment factor as well as the INASI tariff. Thank you. Back to Bu Eva.
Thank you, Mas Febri. Now we come to the second question. This is regarding one of the 3 dimensions of universal health coverage. So the question is, how did the reforms in provider payment affecting out-of-pocket expenses? Maybe this question could be directed towards Prof. Gufron and Prof. Hasbullah. Prof. Gufron, maybe you first. Thank you.
No, I think in the past, and there is also questions how to make more, surplus rather than deficit in the early stage of the JKN program. So of course, we adjust to the need of the adjustment of the contribution. So it was done in the year around 2019 and then 2020. So not only that, but blessing in disguise about the COVID, because of the COVID, then many people were afraid to visit the hospitals. Then the utilization was reduced in that time. Then claim also reduced, then we have the positive. And then not only that, but of course, we have to differentiate. That is what actually, Pak Hasbullah, I would like to add. the function and the responsibility of public health and the personal health. It should be clear stated and should be know exactly who does what. So if we are not able to differentiate, for the public health and personal health, then this can be double of the payment or maybe, financing, not clear channeling, thing like that. So it is very important. And of the WHO three dimension about the coverage and also about the out-of-pocket payment and also the package, how high the package is given. It is really also related to the provider payment. So provider payment should be adjusted as far as this should be related to the performance. The better performance should be better payment and should be, more efficient. But of course, that the health provider should be happier. If they are very sad because we are too efficient, that is not good also. So I think the balance between three actors here, the government, then of course the patient or the community, the health providers and BPJS. So at least four stakeholders should be happier. So to make they are happier, meaning that we have to see each of the stakeholders, and it is of course not easy, but it is the challenge of the Prof. Hasbullah, who is not only professor but also provocators. So it is very important for him to see all, comprehensively the all stakeholders, not only one stakeholders, BPJS stakeholders itself, not only that. Thank you very much.
Thank you, Prof. Gufron. Your turn, Prof. Hasbullah.
Yeah, I think the law clearly mentions that the JKN, the National Insurance Scheme, using social insurance is to cover the medical care, the health care, which in Indonesia we call it individual care, UKP, Upaya Kesehatan Perorangan. While the public health, which the beneficiary are the community as whole, the responsibility on finance and management administration by local government. However, we have to be also objective, knowing that once in the past, local government responsible for both, and now they are just focusing on the public health. There's something that they have to defend, or they want to defend. It's not necessary because they are greedy to control the money, sorry to say, but also because of the lack of understanding what is the role or the overall objective, the common goal, which is making the people healthy. When they are sick, they have to get treatment as soon as possible, while healthcare providers, including those who are managed by local government, will get adequate funding. So the local government should focus on their public health program. This is required transformation or shifting some money that's currently going to the healthcare providers to move to the JKN. So the fund of the JKN will be greater. With a greater fund, the JKN can pay a more reasonable price and making competition, public and private, in the region. So the government should not feel that they have to manage their own public hospital or clinic, for example. If private providers can do it and get adequate payment by the BPJSK, as I said before, the private sector respond much better, much quickly. Then the people get in that local government get benefit the most. So that should be the ultimate goal of us, not seeing I get this and you get those, not that one. Yeah, let's make the people healthy and productive, then the country will benefit from it. Over.
Thank you, Prof. Hasbullah. Thank you also for all participants that has submitted their questions. Unfortunately, due to the limited of time, that will be the last questions answered in this webinar. Over to you, Nida.
Thank you, Ifa. So I think with this, we come to the end of our webinar, and I'll conclude by saying that building on our insightful discussion today, we have delved into the strengths and complexities of JKN's innovative provider payment system. We have seen how it balances cost control with incentives for high quality care, while continuously adapting to Indonesia's unique healthcare needs and contexts. So as we explored earlier, the prospective payment scheme plays a key role in JKN's effectiveness and efficiencies, and a robust, compatible IT system and a strengthened public financial management system, as mentioned, is also critical for JKN's ongoing success in meeting Indonesia's healthcare needs sustainably. The esteemed panelists have highlighted some important areas for improvement. Moving forward, we'll focus on strengthening evidence-based policy making to ensure JKN's decisions are driven by data and explore alternative payment mechanisms that might offer even greater efficiencies. Further aligning of JKN's payment system with the ambitious goals of the health transformation agenda is also an important milestone to achieve in the future. These crucial steps will ensure JKN's continued success in meeting the healthcare needs of the Indonesian people and making them healthier, as Prof. Hasbullah said. I'd like to express my sincere gratitude to our esteemed panelists for sharing their wealth of knowledge and experience with us today. And a big thank you to all of you, the participants of this webinar, for your engagement in this. This is me signing off, Nida Hamid. I am signing off from this webinar, and I am wishing you all the very good rest of the day. Bye-bye.
Nida.
Thank you, Nida.
Thank you, Nida.
Alhamdulillah.
Thank you.
Alhamdulillah.
Thank
you, Bu Eva.
Syukriya.
Thank you,
Syakur.
Prof.
Thank you.
Prof.
Ya, terima kasih.
Hasbullah, Dr. Atik, Mas
Oke.
Febri. Thank you,
Terima kasih.
participants.
Salam.
Mas Febri.
Thank you. Saya leave ya. I leave. Oke.
Bu
Thank
Riris.
you,
Thank you
bye.
all.
Bye.
Terima kasih.
See, Bapak Ibu.
Sore. Waalaikumsalam.